It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preetish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
We have a 40-year-old Asian gentleman with no significant history, now with recently diagnosed intrahepatic cholangiocarcinoma with close margins and diaphragm involvement based upon final pathology. He originally presented with a 4-month history of right upper abdominal pain, weakness, and 30-pound weight loss. His performance status is 1. His medical history is non-contributory, social history is non-contributory, and family history is also non-contributory. In February of last year, the ultrasound demonstrated a 5 by 7 centimeter hypoechoic mass of the right lobe of the liver. CT scan revealed a 7 centimeter lesion of the right liver lobe with delayed enhancement, and his labs indicate his bilirubin was 4.3, elevated transaminases, normal CEA, normal AFP, and a CEA 19-9 of 42.4. He underwent an exploratory laparoscopy, revealing tumor was adherent to the right diaphragm. He underwent a right hepatectomy, partial dissection of the right diaphragm, and cholecystectomy. Diagnosis was cholangiocarcinoma, a 10 by 7 by 6 centimeter tumor, 8 out of 10 mitoses, close margins, and invasion of the diaphragm and lymphovascular invasion. Dr. Siegel, can you comment on these images?
Yes, I can. We have 2 images from a portal venous phase CT, portal venous on the right and arterial phase on the left. And you can see a irregular, fairly poorly defined mass in the right lobe of the liver. Some of the imaging features of intrahepatic cholangio are that there can be sort of enhancing rim and initially, and then slowly with time, the inner portion, which has sort of a fibrous stroma, enhances. Some of the other imaging features of cholangiocarcinoma are dilated bile ducts, and you can see that there are adjacent dilated bile ducts, satellite lesions. There are some other low attenuation lesions here. I'm not certain if they're satellite lesions or not. And then capsular retraction. I don't see that here, but we're not at the edge of the liver capsule. One thing that we can provide that for the surgical team is both with CT and with MR, we can obtain remnant liver volumes. So if the surgeon says they're going to take out the right lobe of the liver, we can measure the volume of the left lobe of the liver, which many times the clinical and the surgical team find is helpful in terms of prognostic evaluation for this particular patient.
Thank you. Dr. Kubi, do you want to mention basically some discussion regarding the surgical procedure and the outcomes, what this means for the patient?
Thank you, Dr. Ng. A couple things caught my attention on this particular case. First of all, the elevated bilirubin ahead of time, puts this at a higher risk for negative outcome after resection. And with a tumor that seems to be more squarely in the right hepatic, in the right liver, having that biliary obstruction would suggest some encroachment on the central hilar structures, making this a more complex resection. The involvement of the diaphragm and certainly the growth in that 2-month period, which was quite substantial, would also put this in a higher risk light. So We actually have a clinical trial started by one of my colleagues, Shishir Maithal, at Emory. Dr. Maithal has a multi-center phase 2 trial for resectable but high-risk cholangiocarcinoma to consider offering preoperative therapy before we would consider resection.
Thank you so much. So given the findings, oops, I apologize. Dr. Patel, given the findings of the diaphragmatic involvement and the close margins, and obviously, as I would like also the opinion of Dr. Benson, is this a patient that you would consider for post-operative radiation therapy to the diaphragm because of the involvement and because of the close margins?
Well, this is a challenging case, and part of it is related to the post-operative anatomy. So a right hepatectomy has been done. It's very difficult to localize sort of what part of the diaphragm might be at risk. And then in that case, you're usually thinking about irradiating sort of a pretty wide area. And now with a right hepatectomy, it's possible that there's bowel in that area. So we tend to sort of consider these on a case-by-case basis. Adjuvant therapies for an intrahepatic cholangio is something where we don't have a lot of prospective data. We can extrapolate in this case from a related study from the SWOG group SO809, where we looked at adjuvant therapy in more distal cholangiocarcinomas. So I think from that study, we can extrapolate that systemic therapy and then chemoradiation is an active regimen. I would say we would look at the anatomy here, and in general, I think I would be pretty hesitant to try to radiate sort of the entire right hemidiaphragm because there's a very good chance that we'll be having a lot of exposure to the stomach and the bowel that's now in that area, which could make the toxicity profile unfavorable.
Thank you. And Dr. Benson, what would you offer this patient for systemic therapy following the surgical resection with these findings postoperatively?
So in terms of adjuvant therapy, if you look at data, for example, from the BILCAP study, single agent capecitabine adjuvant therapy is an option. I think, though, that at least some oncologists would be concerned about these close margins and perhaps would lean more toward combination therapy. So that could include, for example, capecitabine and cisplatin, or even Capox or FOLFOX as a treatment of choice. But I think those would be the regimens under consideration.
And then Dr. Benson or Dr. Siegel, for follow-up for this gentleman that's so young with these very close margins and diaphragmatic involvement after they completed the adjuvant therapy, how would you follow this patient?
Well, I think there's multiple ways to follow. I tend to prefer MR because we can do multiplanar imaging without any radiation. And wanting to look at the diaphragm and the sort of adjacent liver surface, sagittal and coronal images, I think would be very valuable. So I would prefer MR, but I think good quality CT in the right clinical setting could be maybe not as good, could be a close number 2.
Thank you.
Dr. Eng, yeah, I should just mention, I think I left out an alternative regimen of gemcitabine and capecitabine would also be, a combination people would consider.
Thank you so much.
Dr. Eng, I might add, in cases where adjuvant radiation therapy is difficult because it's hard to localize, sometimes, intense surveillance is really critical, because if we were to find a regional or local only recurrence at a time where it was still small enough to irradiate, that might be an opportunity to consider chemoradiation with a more well-defined target.
Excellent point.